On to the next speaker, Dr. Parthopratim Dutta Majumder, Senior Consultant in uvea and Cataract Services, Shankar Netralaya, Chennai. So we'll be speaking on challenges in laboratory diagnosis of uveitis.
Good morning all. Thanks Neetu for having me here. So I'll be talking on challenges in laboratory diagnosis of uveitis, and thanks to Risha who has made my job much easier. So I'll be just showing what all cases Risha has discussed, just how to crack them in laboratory investigation. For example, a patient of anterior uveitis has come to your clinic. So what all test you will do? So there is a tendency that you will try to advise Montu test, anti-nuclear antibody, HLA-B27, torch titers, and serum AC. So we'll see how these tests are done and when not to be done. Now I'll show you two photographs. You just tell me. This test, you can see here that it gives you a appearance of the non-granulomatous anterior uveitis, and Montu test is 15. So will you start ATT? And this is a case which has, you can see that granulomatous exudates, the lump of cellular aggregates in the anterior chamber, often giving a look of mass-like lesion, and it's positive for HLA-B27. So what we'll do? Now, similarly, so we have to understand that no, we don't treat the laboratory test, we treat the disease. So positive HLA-B27 Montu test, highly positive Montu test in absence of a proper clinical phenotype does not matter. Now, one more example I'll give. You can see here the cellular anterior cells, and the patient has come here, a 45-year gentleman, recurrent anterior uveitis, fundus is within normal limit, and anti-toxoplasma IgG is highly raised. Now, will you start anti-toxoplasma treatment? Now, another patient, a 28-year-old lady, retinochoroiditis, you can see that at the edge of the scar with a severe vitreitis, and the anti-toxoplasma IgM negative. So, won't you use toxoplasma treatment? So, this is how your clinical decision will change when you see a proper clinical phenotype. So you have to understand that we are lucky enough and we have a test which is most important in uveitis. This is that we call it microscopy. Now this is not this microscopy I'm talking about. I'm talking about the microscope which gives you a ability to see in 20 to 40x magnification, and we are the only people in this medicine world who can see an inflammatory cells, who can see and quantify the inflammation. We can see whether a blood vessels is inflamed or not. Go to any other subspecialty of medicine. For example, take the rheumatologists. Even they see or suspect giant cell arteritis, they need to send the patient to a surgeon who will do a biopsy and then do a histopathology, and then they will understand that yes, that vessel is inflamed. But us, we can just see and we can tell that this vessel is inflamed. It will require anti-inflammatory treatment. So we need to use this utility very judiciously. So clinical pattern recognition is the key. I'm not going into the details, but you all know how to differentiate between a granulomatous and non-granulomatous, and it is the most important test in your uveitis clinic while you start examining a patient. So try to differentiate between these two and then start your investigation. Now, when we talk about granulomatous investigations, we have so many tests. We have MON2, HRCT and all. So one by one we'll see here, but you can see here that serum angiotensin converting enzyme and serum lysozyme. This is a very important test in sarcoidosis. But sometimes you may have to depend on the HRCT test because these tests are often very less because it represents the granuloma load of the sarcoid, and sometimes in ocular sarcoidosis there can be localized granuloma. So liver function test is important because it is raised in sarcoidosis, ATT and immunosuppressive, so you have to do that properly. Now, Montu test again is a very important test. If it is positive, you know how to interpret and what all of you have given. But if it is negative, then also it helps because the tubercular energy is very important in sarcoidosis. So it gives you an idea that even the tuberculin test is negative, it can be due to sarcoidosis. Remember a few things. Don't treat the patient based on Montu test alone. Don't repeat the Montu test. And Montu test may boost the quantiferon gamma response if the interval between the two exceeds 3 days. So keep that in mind while ordering both the tests. HRCT test is highly sensitive. It is more accurate than the chest X-ray. So always try to delineate that. Coming to the systemic rheumatic disease, if you see, there are so many parameters, but you have to remember three important points. One, no single test is diagnostic, and most of them are non-specific. Like RA is positive does not mean that the patient has arthritis, or ANA is positive does not mean that the patient can have autoimmune disease. Whenever in doubt, do refer to the rheumatologist to look for systemic evidence or not. And sometimes if you have to remember, a biomarker which is negative now can be positive in later part of the disease. A patient has come with fibrinous anterior uveitis, you have done a HLA-B27 and it is negative, but if you are doing the test maybe after 3 to 4 years, it can become positive also. Those things you have to keep in mind. Now coming to the few investigation, I must tell you that don't advise this torch titer, because this herpes viruses are ubiquitous and not required that you need to see the serum, because it can be positive in any patients. Now, just my favorite rule, I always tell that fisherman guides for the laboratory investigation. First, investigation in uveitis is not fishing expedition. You see a case of uveitis and does not mean that you will try to investigate all the investigations you have, because sometimes we'll see that how it can cloud your mental diagnosis. Now, sometimes you have to understand a little bait catches a large fish. Like how it happens, like for example, a patient has come with hypopion or sudden some relapse, and if you are careful enough, that patient is cachectic, very pallor, so peripheral blood smear can actually pick up leukemia. I keep showing one case where the lady presented with VKH like symptom, and then the syndrome, and then it was a case of leukemia picked up only by peripheral blood smear. So peripheral blood smear can be a very useful investigation in certain conditions. The last thing, and which actually relates to the first dictum, is that don't fish for the things you don't know how to cook. For example, a patient of anterior uveitis has come and you have done a ANCA. There is no systemic evidence, but you have it tested for ANCA and ANCA is positive. Now, without any systemic evidence, the patient is having ANCA positive disease is very rare. But you are in a now dilemma because the ANCA is positive, so you don't know how to handle it. So better don't do investigate anyone. So I'll give you again Cochrane's aphorism that before ordering a test, decide what you will do if it is positive or negative. If both the answers are same, then don't do that test. So in certain condition, you have to be very careful that. So I'll just conclude with my how to we take from clinic to laboratory. Determine the predominant site of inflammation, which Risha pointed out so nicely with color atlas like photographs. Try to decode the clinical phenotypes, do a slit lamp examination, take a meticulous history, and also look for the systemic sign. So I'll just follow the Risha's path and I'll just give you 3 examples of how to approach a case of hypopion. For example, we can divide it into scenario A, scenario B, scenario C. So if you see the scenario A patient, we assume that a patient of hypopion has severe fibrinous reaction, non-granulomatous anterior uveitis. The patient also gives us a history of lower backache, and she complains of recurrent attack of attack. So what can be the possibility? Probably we are dealing with HLA-B27 from the history and the clinical phenotype, and we'll order HLA-B27 and only X-ray sacroiliac joints. These are the two. Now assume the second condition, the second patient has a panuveitis, the mobile hypopion, and also gives history of recurrent oral and genital ulcer. Then in that patient, no need to order HLA-B27. Here we'll directly order HLA-B51 and send the patient to a rheumatologist because we are suspecting Behçet disease. Now let's assume the third one, the patients, the granulomatous panuveitis, there is a history of hospitalization in few days back. Our patient is a known case patient of diabetes mellitus, and also gives you a history of a septic foci elsewhere in the body. So in such scenario, as Risha nicely seen you a case of endogenous endophthalmitis, the probable diagnosis endogenous endophthalmitis. So what you will do, we'll just do a vitreous biopsy and send the patient for blood and urine culture. Thank you.
Thank you, sir, for such a great talk. I think with this, we have, it's clear that we have to treat the patient and not the labs. And I would